Great. All right, so I will get started and then I will hand it over. So again, welcome everyone. This is our April 2026 Wisdom Community Forum. Again, please introduce yourself in the chat. My name is Allison Fiscalini. I'm the Executive Director of the Athena Breast Health Network and the Wisdom Study based at UCSF. So just as a quick intro, as with all of our forums, the format is that we do want to hear from you. We want to hear your questions. We do have a presenter, but that doesn't mean that we can't sort of pause and take questions throughout, especially if they're timely. And so please do raise your hand or put questions in the chat, and I can sort of find a time to pause and we can get those questions answered throughout. You can use the chat, as I mentioned, or you can raise your hand, either way. And then we should have some time at the end for a dedicated Q&A session. If you're not speaking, we do ask that you mute yourself. We do want to be able to hear the speaker. And the meeting is recorded. We put all of these on our YouTube channel so that people can access them afterwards if they've missed it, or if there's something they want to go back to and listen to. And we'll put the link to the other recordings in the chat. So if there are other topics that you want to revisit, you can do so. And then we do have a short feedback survey at the end. So we've been doing these forums for, 5 or 6 years now. So we have a ton of different topics that we've been able to cover over the years, many that we've revisited as some of the information has changed or there's updates. So we really appreciate all of you being here and staying engaged, and encourage you to share this forum with your friends and family who may be interested. But the whole mission behind these forums is really to move together toward equity and better health outcomes for all women, and to really have this conversation, hear what topics are important to you that you want to get more information about. You may have heard about things in the news or just interested in topics that you hear amongst your friend groups. And so we really want to bring these topics forward with both the community, but also with some of our health experts who can give some additional information. So as I mentioned, we've covered on a ton of different topics. Again, we'll put that link in the chat to our YouTube channel. But today we will be talking about a topic from contraception to prevention and the role of progesterone receptor modulators in breast cancer risk reduction, which is a mouthful. But I know that Dr. Liberty will be breaking it all down for us and making this topic relevant and understandable. So as I mentioned, our speaker is Dr. Abigail Liberty. She is an assistant professor of obstetrics and gynecology at Oregon Health Sciences University School of Medicine. And a lot of her work is focused around women's health, and specifically around trying to sort of think about women's health across the lifespan, and also how we can sort of bring some of these topics around contraception towards breast cancer prevention and risk reduction. And she has been part of our Rise Up conference and been one of our main speakers and has a whole wealth of information. So with that, I'm going to pass it off to Dr. Liberty. Thank you so much for being here. I will stop sharing, and then you can share your slides.
Thank you so much. I'm going to make sure that you're able to see my screen.
Yes,
is that okay?
Yep, perfect.
Good. And there's a slight echo. Is that maybe where it's projecting for you? Oh, perfect. Okay. Now it's gone. Great. Thank you so much, Allison. And I'm really excited to be here. I'll be presenting a little bit about this area of research that's incredibly innovative and emerging, but I'm going to present with a sort of a historical context about what's been going on in OBGYN for the past few decades. And then really this idea and posing this question to this audience is, what's the future with what we have? And so I just want to start, I think, particularly given that a lot of gynecology and breast oncology historically have sort of a fraught relationship with just naming exactly where I think that comes from. And so I think as an OBGYN and as probably a woman in today's society, we would all agree that contraception is needed for reproductive autonomy. And I think oncologists often agree with this as well, so that OBGYNs don't feel like we're being blamed for some of our therapies that might have repercussions later in life. But I think another really important thing to name, and one of the reasons why OBGYNs feel sort of defensive about our hormonal technologies, is because they are really important not only for contraception, but for overcoming debilitating menstrual symptoms. And so when people sort of poo-poo on different hormonal contraceptives, oftentimes that's a form of ableism. And that's something that we want to protect for our patients. And so I just want to name that. The other thing I want to name, and I'm sorry if you guys can see yourself here, I'll move you to another side, is that when you're talking to OBGYNs, OBGYNs aren't necessarily people you identify as allies based on your history. So many people have reproductive trauma that might be related to gynecologic or obstetric care that they got in their lifetime, and that's okay. It's not okay that it happened, but I want to name that so that I don't want you to feel like you can't say something to me because I'll be upset. I want to recognize that that's a real thing people experience. Um, People also along that line feel that they've been maybe misinformed or gaslit by their gynecologist, and that's also something that we should name so that we can get to full transparency. And then lastly, I want to say that when people are talking about hormones, positively or negatively, that really does identify for people with their identity, whether that's a gender identity or a different time in their life. And
Hey,
I think
Abby,
that, yep,
can I ask you, this is
yes.
Laura, can you
Mhm.
say a little bit more about what you mean about reproductive trauma?
Oh yeah. So I mean, people there's so many kinds of reproductive trauma. We often talk about obstetric trauma where people might come in and feel like they're forced to have exams. They might have gynecologic trauma where exams or words that people use are upsetting. A lot of the words that we
That's good.
talk about force people to think about things that are traumatic, that build on other traumas they've had. And then oftentimes people are coming for reproductive health care based on traumatic experiences, whether that's relationship distress, assault, or other things.
I
Yeah.
see.
Sorry. Yeah. And so people often associate that with seeing a gynecologist like me. And
But
um,
not you, Abby,
but
never
not,
you.
I mean, not me, but like, I mean, if you're coming to me for something upsetting, it's okay to be upset to see me. I just don't want people to feel like they can't ask me a question if they've had gynecologists that they hate in the past. You can still ask. I'm trying to make space so you can still ask me a question. Yeah. But thank you for making that space, Laura.
I just don't want to relitigate the Women's Health Initiative
Oh
completely.
yeah, yeah. Oh no, no, I didn't.
I
I
have,
mean
I
that's
have trauma about that.
Yeah, exactly, exactly. That's exactly what I mean. And I'm just like one person in this huge sea of people, but we can also recognize that. Yeah. So what I was hoping to talk to you guys about today is that the role of endogenous progesterone, which is made by our bodies, and how that affects breast health, and how this has really risen to the front as a potential target. And then I want to talk about two specific medicines that block that signaling, and I'll often refer to them as gum. Like imagine gumming a keyhole, which you'll see a lot of bubblegum imagery. And then we'll sort of end with a discussion about what this means for the future as well. And so, one thing that I often do when I'm talking to patients about the different medicines they're taking is I'll use this analogy of if you imagine a lock on a keyhole, and you need to unlock something to get something critical inside, instructions for a protein or genetic information, in order to unlock it, you need a key. And so, in this description that I often use when I'm talking to my colleagues or my parents or residents, I'll say if you imagine the hormone receptor is the lock and the hormone itself is the key. And that's if you think about unlocking the key to get the information. And when we think about how the breast works, estrogens are the room. And so you have to get into the room. And once you're in the room, and this is true throughout our body, there's lots of different estrogen rooms. If you're going to unlock the progesterone box, you have a separate key. But the most important thing is that you can't get to that progesterone box if you don't first have the estrogen key.
Abby, it's
Yeah.
it's it's funny. I use that same
Oh,
analogy
good.
when I talk about tamoxifen, and I'll often say that tamoxifen stands and guards the door
Yes.
while the aromatase inhibitors take away the keys.
Oh, that's great. That's great. I use tamoxifen. I use the bubble gum for tamoxifen, but maybe a guard is better. That's
They just
better.
block the door, right? They're just
Exactly. Or
standing
I
in front
think
of
they
the
gum
door.
up the key. They gum up the keyhole. So no
Well,
matter
but
how
it's
many
not
keys you have.
irreversible. That's why you just stand in front of it. If you get rid of them,
Oh,
it
I
works
see.
again.
Yeah, yeah, yeah.
Where
Okay.
gum, who wants gum on their shoe or
Okay,
their
well, get ready
sock?
for a lot of gum, but I'll take that
All
feedback. I
right.
appreciate that. Well, next I was going to say the other thing that I think comes up when we talk about these two different cellular responses is it's important to recognize that our bodies make four different estrogens, and they make them at different points in our life. But usually when we use the word estrogen, we're talking about estradiol. And that's just something I like to do as a PSA when I talk to lots of people. But our bodies only make one progesterone, and we abbreviate that as P4. Why is it four if there's not one, two, and three? I can't answer that. But our body only makes progesterone. So there's only one key to that lockbox. So then, one thing that I spend a huge amount of time doing is talking to gynecologists. And gynecologists really love this idea of what's happening in the ovary. And this is a classic textbook example of what's happening every menstrual cycle. And so every menstrual cycle, about 10 to 15 oocytes or follicles start competing. And it's like Machiavellian. We all think about sperm and a race to the end, but that's not very complex. What happens in the ovary is this like amazing complex race. And they're all stealing blood vessels and energy, and they're making lots and lots of estrogen. And the person or the follicle that makes the most estrogen ruptures in this a beautiful event called ovulation. And then it forces the rest of the follicles into submission to make progesterone. But they themselves do not have enough energy or signal to make progesterone indefinitely if there's not a pregnancy. So a pregnancy would have to switch them on so that the corpus luteum would continue making progesterone. And this is a phase that is in all of our textbooks, all of our exam questions are about this. But we really should be thinking about how this affects the breast, because every month when you have these keys or these hormones that are circulating throughout the body, they're affecting the breast. And so here you've got the keys, which are the estrogens and progestin made by your body. And then this is the lockbox that you're trying to get into in the breast. And so in the beginning part of the cycle, when hormones are low, the cell, the lobule, which is the end, or the beginning sort of the breast, the functional unit is this really tight ball. And then as estrogen rises, it separates out into this bilayer. And you've got the luminal epithelial cells and the myoepithelial cells, and you can see it really clearly. And then when progesterone's there, the body has received the signal, okay, ovulation happened. I need to prepare for a pregnancy. And all of the cells on the inside of that lobule start making tons and tons and tons and tons of protein because they're getting ready for this party of a pregnancy. But then that doesn't happen. And all of these immune cells have to come in and clean up that would have been a party. And that takes a lot of energy. There's a lot of swelling and there's a lot of inflammation associated with that process.
And actually, what's very interesting, when you look at this, and you think about it, we tend not to do it just because it's so complicated to schedule. But truly, if you were getting an MRI
Mhm.
and you did not have an urgent need to get it, and you just to get it whenever, you really want to try and make sure that you are getting it like starting 3 days after your period starts to, maybe
Right,
10 days,
right
that you
here.
really want to get it in that follicular phase. And then what you really want to avoid is having your MR in the luteal phase, because what you get is a lot of background enhancement. A lot of stuff just lights up.
Mhm.
And I think that's very interesting. And that is yet, as we think forward a little bit, Abby, and sort of what the influence of progesterone is on the breast, even short term,
Mhm.
we can see it cycle to cycle. And so when you're trying to run trials to look to see whether people's risk is reduced, then you really want to try and time it, because it does absolutely make a big difference,
Yes,
or it can.
yes.
And
Yeah,
that
and I mean,
explains a lot. Mhm.
mhm. And so this idea of this like cyclic thing has been described as sort of a roller coaster, and it's the ups and downs and the ups and downs and the ups and downs that are fatiguing for the body. And each up and down is the risk that you could develop like a new mutation or some sort of pathogenic process. And then other people describe sort of that inflammation with the drop in progesterone at the end of your cycle as sort of like a wound-like physiology. And both of these have been explored as sort of pro-tumorigenic niches, and a potential reason why we see this specific risk with a otherwise normal physiology.
And can you define tumorigenesis for us?
Oh, yeah. So this is like normal cells that develop a capacity to grow unregulated and a capacity to invade. Unless Laura, you would jump in and say something else.
No.
Yeah. So they like steal things. They like learn from what's happening, and then they like it turns into something else that the body can't control. Thank you. And so this idea that it's progesterone is actually reflected in all of this epidemiologic data that we have. And so the idea that progesterone from menstrual cycles are conferring a risk of breast cancer over time is reflected in the fact that early menarche, so when you start your period early and you have later menopause and you end your period later, that means you're having more menstrual cycles in your lifetime. If you don't get pregnant, you have about 450 menstrual cycles in your lifetime. And the more pregnancies you have, the fewer you have. And so that could be part of the protective effect. If you never get pregnant, which is nulliparity, there's an increased risk of breast cancer with that. And then there are genetic conditions that we sometimes manage in gynecology where people don't have progesterone signaling. They can be disorders of puberty or other sorts of disorders related to signaling. And there's no breast cancer in populations that have those, which is another proof of concept that progesterone is needed for probably many kinds of breast cancer. There's also some controversy, and this is an area I study, about contraceptives. And so we have contraceptives with estrogen or with progestin only. There's no estrogen only contraceptives. They all have to have a progestin. And even with progestin only contraception with no estrogen, we still see a small risk of breast cancer. And there's some really interesting biology there that I do some research on. But we're not going to talk about that here. The most important thing for people to know is that not all progestins, which are the synthetic versions of progesterone that we make in different therapeutics, are the same. And we need more research about what it is about different progestins that might confer a risk or not. But because we've sort of established that progesterone from menstrual cycles confers a breast cancer risk, the question becomes, can we target progesterone instead of estrogen? So instead of blocking the door to the room, which affects every room in your whole body, can you block just the lockbox on the inside of the room and then maybe have fewer symptoms because you've targeted the prevention more specifically? And so the way I do this is I think about receptor modulators like gum in a keyhole that's blocking the keyhole so that you can't get in. And we have tamoxifen, just like Laura explained, which is a selective estrogen receptor modulator, so blocks the keyhole to get into the room. And then we have two medicines that are available, but there's a whole class of medicines that are progesterone receptor modulators, or they block the keyhole for getting into the box that has the progesterone effect. And the two that I'm going to talk about for the rest of the meeting are ulipristal acetate and mifepristone. And so
So
ulipristal acetate.
one sec before we hop into this, are there any questions? Anything that just setting this up for the next part of the discussion? Any questions? Okay. I see a couple notes in the chat to maybe just slow down a little bit.
Always.
Yes, I know. But yeah, if you guys do
Speed
have questions,
16
please
for you,
do
Abby.
put them in the chat. Yeah. Yeah. Okay. Thank you. Go for it.
I talk fast because I'm so excited, and I apologize that I have to temper my excitement and slow down. But I will make an effort. So thank you for that.
Yes.
I was going to say that the first medicine that I want to talk about is called ulipristal acetate. And in America, we often call this UPA. It's just a shorthand that we use. And I apologize that you have to use any of your bandwidth to have to toggle between the full name and the abbreviated name. But the trade name in the United States is Ella, and the trade name internationally is Ella 1. And so this is a medicine that most people think of as Ella rather than UPA. And I want to talk about this one first because it's what we have available in the United States. And so Ella 1 is a form of emergency contraception. And emergency contraception, we often in gynecology call this postcoital contraception. And so it's a way of preventing pregnancy after somebody has had an encounter that puts them at risk. And this medicine in particular can be taken up to 5 days after sex that might result in a risk of pregnancy. And it's really important to know how it works. So it works on the follicle. So when I talked about that class of all those different eggs that were competing and trying to rush and like waiting for the signal about who's going to be the winner and who's going to be the luteal, the corpus luteum, this interferes with that signaling. So, and it just interferes with it by delaying it, and it very predictably delays it by 5 days. It's important also to think about it as emergency contraception because that name conveys a certain value. And so, most people, you probably, even in this moment, when I said emergency contraception, maybe thought about experiences you had had, or you had a mental template of somebody else seeking out emergency contraception. And we know that it's highly stigmatized, even in our medical language, as sort of a failure or a backup plan or something that you didn't really want to happen. So you're going to try it like a band aid. But in reality, I spend a lot of time talking to people about how if an individual identifies a risk and then takes an action to mitigate that risk, that's actually a huge success. And we should be talking about emergency contraception early and often so that we destigmatize it, so that people that would benefit from these are able to get them. And talking about it early and often is important because it's highly underutilized. So even among people who've experienced an assault, a sexual assault, who go to the ED, they're only offered emergency contraception about 20% of the time.
Mm.
And so that alone for me is imperative for why we should be talking about it and destigmatizing it so that people can ask for it or know if they're not getting the standard of care. I want to take this moment to also recognize that a lot of people think about Plan B, which is another trade name for a different kind of emergency contraception. But actually, Plan B is a progestin or a synthetic copy of progesterone. So it is the opposite biochemically from ulipristal acetate, even though we're using it in the same way. And the way that we think Plan B or leave-in adjustable prevents pregnancy is different. And that's why it's less effective and it only works for 3 days. So I just want to say right now, the form of emergency contraception that we're talking about is ELA, which is ulipristal acetate. And then the last thing that I always talk to people about is advanced provision. And so that is a systematic change where we're decoupling the pregnancy that puts you at risk and the medicines that can help reduce that risk. And by decoupling them and talking about them before you're at risk, we can give you the medicine so you have on hand just in case. And when we started advocating for that as gynecologists, we got a huge amount of pushback. And everybody was like, oh no, people are going to stop using condoms. They're going to have really risky sex. They're going to have more sex. And they did very, very rigorous studies around the world. And they found out that that does not happen. The only thing that happens when you give advanced provision of ulipristal acetate emergency contraception is that people are able to take it closer to the exposure. They don't have to wait for a doctor's appointment, and they don't have to wait for a prescription, and they don't have to go to the ED. And that makes it as effective as the perfectly controlled clinical trials, which is what we want. So ulipristal acetate was developed in the United States as emergency contraception. And shortly after it was developed in other parts of the world, they thought, how can we use this class of medicine to treat other conditions that we think in gynecology are mediated by progesterone? And the one that was very, very pressing was fibroids. And so in Europe, they developed a form of ulipristal acetate that was low dose. So instead of the 30 milligrams that we use for emergency contraception, they had 5 milligrams, which you could be take every day. And they gave it to people over 3 months, and they found that it was life changing for people with fibroids. So, fibroids are benign growths that happen in the uterus. They can happen on the part of the uterus that bleeds, or they can happen in the part that pushes on the bladder or the rectum, or they can happen on the top, and they can cause pain, uh, really intense bulk symptoms, depending on what they're pushing on, and they can cause incredibly heavy bleeding. Most people take the emergency or they take just regular contraceptive pills, but a lot of people are not medical candidates for those and they're not able to take them. And so this was a highly effective medicine because it overcame the need for estrogen in people. And this was an estrogen free treatment they could take. The only other option is surgery, which has a lot of morbidity associated with it. And so this medicine became available in Europe and people were using it and they had incredibly positive reactions and the reaction specifically was reduced bleeding. However, around 2020 during COVID, there were some concerns that there was liver toxicity associated with sort of widespread use of this medicine. And European and Canadian markets said you cannot advertise or prescribe it anymore. And so this medicine went away. And so it's very hard to get it in Europe, and we've never had it in the United States. And the rate of drug induced liver toxicity associated with this daily medicine was about 11 per 100,000 uses. And then it was even less likely that that would be super severe. So less than 1 per 100,000 people had a fatality from that. But that's real. That happened, and that was real morbidity that happened. However, when we think about how likely is that to happen, we need to compare it to other drugs. And so I've listed here, sort of in the corner, some other medicines that you might have heard of that I commonly prescribe in gynecology. So there's metronidazole, which is a pill that we use to treat bacterial vaginosis or a common infection of the vagina. And that has almost an identical drug induced liver injury to esmia. the medicine that was in Europe, but it's still widely available. There's no additional monitoring that you need. And then other drugs that have just a little bit less, but are sort of on the same scale, are things like Augmentin, which we use for treating infections, and Bactrim, which we use for UTIs. And so these are medicines I've taken in my life, maybe you've taken in your life as well, and nobody fear-mongered or told me to be afraid of this, and nobody checked my liver enzymes before I took them, but this risk is real. So really, the question becomes to me, this medicine is not available because of the safety concern. So are we going to let that be the end of access? Or is there a way to move forward and develop monitoring or risk stratification or screening to help reduce that risk? And then the second question that's always in the background, but hard to pin down or talk about, is that, this medicine is clearly being treated with more stringent requirements or expectation than other medicines, right? And so to what extent is that reflecting our society's perception and value of women's health conditions? And this commonly comes up in these statements about Esmia and removing it from the market. They said, well, people with fibroids are healthy, so you can't give them an increased risk through a medicine because they're otherwise healthy. And to me, I think you can be healthy with fibroids, but you can also be suffering. And that argument minimizes the suffering that women with fibroids have endured. And I think it would be more patient centered to have a discussion with them about what risks are acceptable or not acceptable to them relative to the other treatment options, instead of just saying paternalistically, we as a society say this risk is not worth it for you. So this becomes even more important because there were studies that were ongoing at the time of the revocation in Europe that were allowed to complete, and those studies have since been published. And so the first one I like to talk about is by a gynecologist in New York, and she was comparing Esmia, although a slightly higher dose of it, so 10 milligrams daily for 12 weeks, to the oral contraceptive pill in women. And they were taking breast biopsies before and after and getting MRI. And they saw in the 13 people that took UPA that almost all of them, so 6 out of 7 that had paired samples, had a decrease in their BPE from the most, this is exactly what Dr. Esselman was talking about, from the highest background that is present almost always to the lowest, which made the imaging much easier to interpret and definitively make a recommendation for. And they also saw on their biopsies that most people had a decrease in the Ki67, which is a marker of a cell in sort of a growth phase, or what we call proliferation.
And just to define BPE for those who aren't
Oh,
familiar.
yes, thank you so much, Allison.
Mhm.
BPE is background parenchymal enhancement. It's sort of like density on a mammogram. It's like how much background is there? How easy is it to see the area that we're looking for? But it's not exactly density. It probably reflects a little bit more function of the breast rather than just tissue.
What it actually is measuring is blood flow and blood supply and leakiness of vessels. So MRI, that contrast, if you've ever had an MRI and they give you an IV, they're putting this gadolinium or contrast material. And what MRI is doing is looking at the uptake of contrast and washout, how fast it's taken up and how fast it washes out and where in the tissues it goes. And you can see on the top, it's kind of like a whiteout. That's all from blood flow. And you can see the person in the bottom has almost none of it. So clearly inflammation can make can cause there to be more and more uptake of the contrast. Infections can cause that. Cancers can cause that. So enhancement on an MRI is not specific for cancer. Just so happens the cancers have leaky vessels and they can rapidly take up the contrast and then it washes out. So that's the rate at which it's taken up and washed out can also tell you a lot about whether a condition is cancerous or not, but you can be fooled. And sometimes you just can't see behind what's going on.
Mhm. And that's, I think, oftentimes when I'm reading these, and I'm not a radiologist or a breast oncologist, but the BPE, this white washout, makes it harder to tell if there's a small lesion. So it's like a
Right.
masking
So it's
effect.
both just like you can have a lot of density, and on a mammogram, the same thing can happen here. So breast parenchymal enhancement, this kind of uptake in the back, is an actually independent risk factor um, uh, from breast density. They are both risk factors and they're both independent. So that's actually interesting. So we think about the microenvironment or whatever that environment is. We also know that if you gave someone like on the top tamoxifen or even baby tamoxifen within a month, a lot of that can just go away. And we are trying to understand biologically what is going on and what happens to someone whose background doesn't get better.
Mhm.
It's not just estrogen signaling, it's probably some kind of inflammation or inflammatory process.
Mhm. And so this study was the same phenomena was observed in another study, and this other study had much more in-depth understanding of what was happening at the molecular level. And so this was a study from the University of Manchester that was published earlier this year, so in December. And they had 24 women. And this study was specifically women at high risk of breast cancer. The other one was just, there was no risk stratification for enrollment. And they found when they gave UPA to their people that there was significant remodeling of the breast through multiple mechanisms. And so here they're looking at Ki67, which again is that measurement of growth or proliferation. And here it shows up as all of these bright dots that you see sort of throughout the microscopic view of the breast, and then it's gone after UPA. And they also did MRIs before and after, and you can see here that there's a lot of signal in this top MRI that's shown in the bright red, and then there's significantly less signal in the second one. But they also did studies to identify what was changing. And specifically, they saw that between the baseline and after the drug, that the number of sort of the breast stem cells, so the cells that we think have the ability to grow into cancer or are most likely to grow into cancer, was reduced significantly by this drug. And very interestingly, the scaffolding around all of the cells, which we call the stroma, but it's also oftentimes collagen and fat, was more permeable. So there's remodeling of the structure around the cells, which might help your body get in and fix any mistakes or clean up after that party. But also, there's just less trash generated because there's less proliferation. And so this was a really big landmark study that we've been waiting for a couple years, and it's really exciting to see it published. And when I
There's
first,
a, oh, sorry, one question in the chat. What is considered high Ki67?
yeah, so they often look at a percent. So I think, for cancer, they look, it's pretty low. It's like 3 to 5% of cells are Ki67 positive. Um, and that's considered like if it's above that threshold or 10, if it's above 10, it's considered like
No,
high Ki67.
no,
Here,
that's actually
oh, I'm sorry.
no.
Sorry.
You can have, and actually, if you have 10% or less, that is actually reasonably low. And a lot of times what we will do, and it really depends. You can have, if we know when we look to see, well, what happens if you have things that look like they are suspicious on an MRI, but they turn out not to be cancer, that we call a false positive. Often you'll see more blood vessels, more cells turning over. That's what Ki67 is, just looking to see whether what's in the nucleus of the cell. It's a protein that lights up during when the cells are reproducing or turning over. 20 sort of intermediate. High, you can have, very high is like 60 to 80%. Those are
Mm,
only usually tumors grow at that kind of rate. And the different kinds of tumors have different rates of Ki67. Now, Ki67 is also can be very operator dependent, very variable. So it's not like a perfect test by any means, but sometimes what we'll do when someone comes in with a hormone positive breast cancer, you know, even a couple of weeks before they go to the operating room, giving a couple of weeks of tamoxifen can actually help us understand if the cells are the if we can turn them off, with an anti or with some, with something that's blocking the estrogen door, right? Um, but we also know that if you give someone a month of tamoxifen, you'll see that enhancement go away. So same thing. So again, this is like an intermediate endpoint. It's a surrogate. That's what we're looking for. We're looking for markers like a cholesterol or something that's telling us, up, your risk is high, now your risk is lower.
mm.
Those kinds of things.
And there's great data about how Ki67 changes across the regular menstrual cycle.
I'm sure,
And
yeah.
I'm happy to share that data. It's like pretty low. And this study, I think they just looked for a continuous. So they just said, how many Ki-67 positive cells were there before? How many were there after? And based on statistics, would we expect that?
And I would imagine that the Ki-67 goes up after the follicular phase, so in the luteal
Yes.
phase, and then
Yes.
goes down,
Mhm,
right? That's
mhm.
consistent with what we see on breast MRI,
Exactly.
background, et cetera.
Mhm,
And yeah, and consistent with what we know about progesterone causing cells to divide. I mean, that's not new. That's
mhm.
been known since the 80s. Ron Ross and Malcolm Pike, are the ones
Yes.
that pioneered all that. Yep.
Okay. Well, I was going to say that when I first saw this presented at a conference, it was in England, and an American oncologist, stood up and said, "Why aren't we giving Esmia to everybody?" They were so compelled by the results, and I just gave you the top results. These results went really deep into cellular programming and the types of collagen and immune infiltrate. And the presenter said, "Well, there's this like liver toxicity if you like take it too long, and so we're not really sure." And that moment was so hard for me as an OBGYN in the audience because I recognize that the oncologists want a medicine that you can take forever to help prevent breast cancer. And so this Esmia specifically in its current form, that's hard to get, might not be that medicine, but we can't give up on it because we have other medicines that have other uses that we can innovate and think about and continue to refine this so that we can reduce the risk through other ways. And so this inspired me to say, all right, if you saw these changes on MRI in 2 studies now that were so profound, could we use the similar thing for mammographic screening? Could we give ulipristal acetate in a certain regimen that might temporarily decrease density? Because I see many people that have very dense breasts that are getting screening in their 40s, and their radiologists are saying, well, the sensitivity is only 50% because of how dense your breasts are. And maybe those people need a pretreatment to make their mammogram more effective. And so that's a study that we're doing right now as like an innovative use, possibly, of this medicine that looks like it's likely has unique breast effects that we think are protective. But the other area that I see all the time that I think UPA is underutilized is among people with breast cancer who need different contraceptive tools. And so right now, I have in my clinical practice, I see people with breast cancer, and I've seen many people that get a biopsy or a concerning image and they immediately stop their hormonal contraception. About 60% of premenopausal women are using hormonal contraception at the time of their diagnosis, and they're making that decision on their own, which and are supported by their healthcare providers. But I have seen several people who get pregnant between when they first get that suspicion and when they come in for their mammogram. And I've cared for at least 2 people whose mastectomies were canceled because of an unplanned pregnancy at that time. And I would say, and that was devastating. Both of those people ultimately got the care that they needed, but it was a really devastating delay. And as an OBGYN, I would say preventable with education. And that includes education about, condom use, and possibly if somebody's transitioning to pericoital methods, offering them ulipristal acetate emergency contraception because current breast cancer is not a contraindication to use. And so that's a tool that I think is incredibly important for people to be aware of to help prevent delays in their care. Next, I'm going to pivot and I'm going to talk about another progesterone receptor modulator. And
Or
this
before you move on,
yes, please.
sorry, before you move on, there was a question about Ella,
Yeah.
and it sounds like it's available. It's not just emergency room available, it's available elsewhere, correct?
Yes, you need a
And
prescription for it. I'm sorry.
you do need a
You do
prescription.
need a prescription. It is not the one that you can
Okay.
buy over the counter. In America, you need a prescription
Okay.
for it. There are other
Okay.
countries where you don't.
Okay. And I think the question was, so it sounds like you can get a prescription for it, or in the emergency room department, could it be the automatic offering instead of having to ask for it, for example? And I think that's the point you were trying to get to, is that it's not offered enough and people have to ask for it and they don't because they're afraid or scared or
Mhm.
whatever else. Yeah.
Yes, that's exactly true. I mean, also, not all providers feel comfortable providing it
Hmm.
because of its potential association with the next medicine I'm going to talk about. So,
Okay.
like, sometimes providers are not comfortable with this whole class. And that's because of this medicine, mifepristone, which you might have heard about or read in the news, which mifepristone is from the same class of medicines as ulipristal acetate, and it's licensed as part of the regimen that we use for medication abortion. And for this reason, it's often called like the abortion pill. And I'll talk about that on the next slide. We do use it for medication abortion in the United States and around the world. And in the United States, because it's only FDA approved for medication abortion, anytime we use it for miscarriage, which I would say clinically is about half the time I prescribe it, it's technically an off-label use. So it's not a use that's like protected by the current FDA. That is true in America, but not globally. Globally, they are treated the same. And this medicine, because of its association with abortion, is under intense and constant political threat. And so there's a lawsuit last week about decreasing access to mifepristone. There have been multiple lawsuits throughout different states and going to federal courts and against the FDA about restricting access, all because of the association with abortion. However, as an OBGYN, this is sort of hard to wrap your mind around because mifepristone alone is not an abortifacient. It has to be taken with misoprostol. And misoprostol is a prostaglandin, and they need to be taken together. One alone is not enough. You can take lots of misoprostol in a specific regimen and achieve it without any mifepristone. But the way most people like to induce a medication abortion or manage a miscarriage is with these two medicines together because it reduces the unpleasant side effects. But currently, mifepristone is the one that's sort of branded as the abortion pill. And this is just important to recognize because all of these attacks on mifepristone have implications for other healthcare. And so the way I often think about attacks on healthcare is sort of an erosion of reproductive rights. And what might that mean for breast cancer? So right now in the United States, mifepristone is under attack. That has been a constant thing. However, there have been other attempts to regulate misoprostol. So right now in Louisiana, and there's current litigation in South Carolina that are trying to list misoprostol as a controlled restricted substance, similar to narcotics. And so it's not just Miffy, it started with Miffy, but it's not just mifepristone that is at risk. And I often talk about that to breast oncologists because other hormone modulating medicines have been studied in the context of abortion and are used around the world for different medication abortion regimens. So, letrozole, which is an aromatase inhibitor, can be used. In a certain dose and frequency to help with a medication abortion alongside misoprostol. And so I would say if you're not afraid of mifepristone going away, and you're not afraid of misoprostol going away, that you should consider if the precedent is set that medicines that can be used for an abortion are deemed unsafe politically, then we should be concerned about that letrozole. And there are also studies that look at tamoxifen, and tamoxifen can also be used for these same reasons.
Abby, can you explain why mifepristone is given with misoprostol
Yep. So
to people?
mifepristone, yes, exactly.
Yeah.
So mifepristone, it doesn't take the progesterone out of your body, but it quiets the signal because it's gumming up the keyholes. And so progesterone is one of the most important signals for your body to maintain a pregnancy. If you give it alone, it doesn't cause the pregnancy to end. It doesn't make the pregnancy come out. It just sort of weakens the pro-pregnancy signal that's in the body. The How sensitive the pregnancy to is to that signal depends on sort of the gestational age and the underlying health of the pregnancy. And then the misoprostol causes contractions, really intense contractions that cause the release of the pregnancy. And both of those together can help somebody release a pregnancy. Normally, it's a 4-hour, very sort of intense, crampy experience with bleeding. A lot of people are accessing medication abortion online these days, which we call self-managed, which has been shown to be safe around the world. But the first is a hormonal priming, and the second is an inflammatory contraction, is how I would break it down. And so people that use letrozole for abortion, which is like not the optimal regimen by any means, have to take letrozole for several days, which decreases the hormonal stimulus in the body, and then they can take misoprostol. Mhm. I like to always talk about this because even though mifepristone is associated with abortion in the United States, that's not true around the world. And in countries that don't have a predisposition or a reticence to studying mifepristone, have done really innovative things. So I don't know if anybody here has ever had an induction of labor where they're going to have a baby and then the OBGYNs place like a Foley balloon, which is like a catheter that goes through the cervix and sits on the inside, and it's really horribly crampy. There are studies that show using mifepristone instead of a Foley balloon are just as effective. And so these are using mifepristone in pregnant women at term with live births is safe and being done in other countries because they know that alone this is not an abortifacient and they are not worried about how it is affecting the vitality of the pregnancy at that stage. It has also been used similar to ulipristal acetate as emergency contraception. Sorry, Allison, did you want to jump in? No, okay, perfect. As emergency contraception in some countries, although in a different dose than what we use for medication abortion or medical management of miscarriage. There's currently a study that everybody is very excited about that's going on in the Netherlands, and they're looking at mifepristone once a week as a hormonal contraceptive. And this is done by Rebecca Gompers. And this study is so popular as a non-estrogen weekly contraceptive method that there's a wait list for trial participation. So they're optimistic. I saw her speak last week. They're optimistic to recruit their recruitment of just under 2,000 women within the next year. It'll be a record for fastest study recruitment. Maybe Wisdom will
And
rival that.
is one of the outcomes looking at breast cancer risk or any breast cancer outcomes?
Yeah, that's a great question. So I have spoken to them about this specifically, and they are collecting self-reported breast imaging or breast symptoms. They are not prospectively imaging people in the study at large or taking any biopsies.
Too bad. They should just try and do a small cohort, like 10% or
Mhm.
even 20, 30 people.
Yeah,
But so this is going to be just once a week. And what's the dose of mifepristone that you use for when you're trying to end a pregnancy?
it's 200 that we use to end a pregnancy.
Okay,
And that's just one time.
so again, like a quarter or fifth the dose, right?
Absolutely. Mhm. Write that down and include that in your studies, Dr. Esserman. This is very well tolerated. So usually OBGYN studies, one of the endpoints so contraceptive studies are designed different than other studies because you have to really identify and isolate the risk of pregnancy,
Yeah.
which is based on coital frequency and other things. And we tend to track bleeding outcomes because bleeding profiles are one of the strongest predictors of who will continue a contraceptive method. So the patients in the study are doing a significant bleeding diaries and report of spotting or breakthrough bleeding or things like that. And it's a lot on the participants. Sometimes they do ultrasounds to monitor endometrial thickness and things like that.
So, you know, Barry Kahn at the first Rise Up meeting had said he thought that basidoxifene would be such a good tool that could really be a great contraceptive because it's just absolutely hostile to anything implanting in the uterus. So is that really what mifepristone is doing?
Meaning is the contraceptive mechanism of action through uterine changes?
Through
That
just making it difficult for the uterus to accept and allow the egg to implant. Or
yeah.
the egg to get the buildup of the lining so that it can support or nurture the growth of the embryo.
I think that's likely a part of it, but I think they're also monitoring how often people are experiencing ovulation as well. And so
Will this interrupt ovulation?
they think it will. So you're sort of perpetually delaying it.
Which also is interesting. So this is some of the early work that Malcolm Pike did, and the idea of really trying to reduce the number of cycles that people have, with the idea that that's one of the things that drives breast cancer risk. Because when people have kids when they're very young, breastfeed for long periods of time, and then have more kids, et cetera, this long, you can spend 15 years when you're kind of not cycling. And that in the 90s was really thought to be a really important mechanism for how breast cancer risk. And then people will go into early menopause. And so that would really reduce the total number of cycles, and that there's good epidemiology data showing that across the world that would, that the fewer number of cycles you had, the lower your incidence of breast cancer. Of course, it's not the only thing. But it's interesting because the birth control pills that keep you from ovulating don't seem to do that, don't seem to reduce the risk of breast cancer, which I find somewhat confusing. But
Yeah, I have my theories on that, which I'm happy to share, even though I didn't prepare a slide on it. Most of my clinical trials are not on progesterone receptor modulators, even though I provide abortion care and prescribe these and emergency contraception all the time. Most of my studies are looking at the hormonal IUD and where people have ongoing ovulation with a low level of progestogen in the background. And the progestin that we've used for decades and decades and decades is really strong. And the breast cells look a little different. They look like they're kind of in that party phase, planning for the party, even though there isn't been an ovulation. So I wonder if the risk that my hypothesis, which we'll see one day, if it's true or not, is that with hormonal contraceptions, with certain progestins, specifically levonorgestrel, if we've sort of put people in this low level luteal phase, even though they're not
Yeah.
having spontaneous ovulation. Mhm.
Yeah. So something like mifepristone
Mhm.
might be great because it is avoiding that.
Yes. There's other contraceptives. I'll just name them really fast since you asked. So, drospirenone, which is a
Yes.
progestin that looks like it's not nearly as stimulating on the breast. It's available in a progestin-only formulation called Slind. And another one called Nextstellis, which has an estrogen that is not estradiol, and the estrogen that's in it is estetrol. So it's a naturally occurring estrogen that
The
looks
fetal
like,
estrogen, right?
exactly, yeah, that looks like it blocks the estradiol effect.
They got into big trouble by claiming
Hmm.
that it was reducing the breast cancer risk.
Yeah.
And they got a
Cease and
letter,
desist. Uh-huh.
a cease and desist, which actually kept them from being acquired.
Yeah,
Very
that's
interesting. And
yeah.
it's too bad I had told them they should just have tested it with some MRs to see whether
Laura, I
any.
just asked for money to do that. Yeah. So we'll see. I said that would be easy to do.
Yeah,
Um,
I mean,
mhm.
they should have done it.
Yep. Yeah.
And anyway, but
Yeah.
see, nobody wants to, no one wants to do the hard work. They want to,
I will say contraception does not get a lot of funding compared to other things because most people say, well, there's a pill and it works. So what's there to improve upon? So it takes a huge amount of scientific effort and advocacy from advocates like the attendees here to say, no, we have a pill. It's good at preventing pregnancy. We need it to be better. We need it to reduce our risk of breast cancer. We need it to address these mood side effects. We need it for other bone density. And that's an area that gynecologists are interested in, but it's just really hard to do it alone. So thank you.
what are the things that cause mood issues the
Mhm.
most? What,
Yeah.
I think people often want to know about that.
Yeah. So there's mood gets really complicated because it's a super diverse sort of physiology. A lot
Mhm.
of people report negative mood effects based on the progestin. And we know that progesterone is synthesized locally in the brain and that the allopregnanolone, so like the metabolite of progesterone, is really important for certain moods. And people probably each have their own set point. They might be sensitive to too much or too little or to the roller coaster, and we don't have a way of predicting who that will be. But I would say if you had mood effects, it was real. And if you want to try a different progestin, there's evidence that it might be different, but we don't yet have the data to say this is what your sensitivity is, and this is the best hormonal contraceptive for you. One day.
Uh, we just have about 5 minutes left. I
Yep.
know you just have a couple slides left.
Yep.
So yeah.
Perfect. Well, I was going to say that we have known for a long time that mifepristone induces similar effects on the breast to ulipristal acetate. And these studies primarily come out of the Netherlands. And they saw, again, the reduction in the proliferation marker, Ki67. But they also looked at what they called mitotic age, which is as we age, our DNA accumulates all kinds of chemicals on it called methylation. And they found that when you gave mifepristone, you saw a protective reduction in methylation in breast tissue. And this was present in women that didn't have any history of cancer. And it was also present in BRCA carriers. And that was a really positive finding out of this study that this is data that helped them argue to study ulipristal acetate, which could be taken daily. Mifepristone has also been given to people with breast cancer, although the data for this is much more diverse. There was one study out of Buenos Aires that gave mifepristone 200 milligrams every day for 2 weeks before a definitive surgery, a mastectomy or lumpectomy. But they had the biopsy at baseline, then they had their exposure, and they had their surgery. And they found that the tumors looked different. This was exactly what Dr. Esselman was talking about, similar to tamoxifen. So they saw changes in how many immune cells were able to get into the tumor. So they saw more immune cells around the tumor after mifepristone. They saw that the tumor itself was not growing as much as it was on the initial biopsy. And these were considered proof of concept that mifepristone could be used perioperatively or as part of a treatment for people with breast cancer. However, when you do a literature search and you look for mifepristone for breast cancer treatment, you don't find a conclusive positive effect. And this is usually because it's only been studied in the setting of metastatic disease. And likely the biology at that point is so diverse among people that it's hard to say they're a single group that could benefit, because likely they've all had sort of different tumor journeys, and their tumors might not all behave the same way.
And very interesting, as you know, the person, Martin Windenbender, who we gave one of the Spark Awards to, actually has demonstrated that mifepristone actually reduces that so-called methylation, or those
Hmm.
changes to some of the cells. And he's developing pretty strong data that it would be a pretty good preventive for, they're testing it. He's part of that group in the Netherlands, and he was in Austria trying to test it as a way to reduce risk in BRCA carriers who don't want to have prophylactic mastectomy when they're young, when they come from one of the families that has really, where they really have strong family histories of an early death from breast cancer. So
Yeah, that would be huge.
TBD. So, and he's got
Yeah.
some really excellent methylation markers, and that's what he was talking about, is like, how would you, that it should work on all kinds of cells in the body. And I think this is part of the problem, is it's sad that we can't get some of this work done here
Hmm.
because there's such a hostile environment towards
Yes.
studying any of these medicines when clearly they have an important potential role here.
Yeah. And that was exactly the note that I was going to end on, which is that, I hope today that I've shared why I think progesterone is such an interesting target in breast health, in ways that I think that we know how to modulate. And we do have medicines that can affect the progesterone signaling with significant fewer side effects than medicines that affect estrogen signaling, but their use is restricted for some good, biologic reasons, not insurmountable in my opinion, biologic reasons, but primarily for political reasons in our country. And that's going to really limit not only therapeutics, but also our understanding of the biology for other knowledge that we can acquire. And so really the most important question is, what do we do moving forward? And that I was going to end right there.
Thank you. That's wonderful.
I've got
There was
plenty of time for questions. Yeah.
okay. There was one question that just came in when you were talking about that last study, if they looked at macrophages.
Um, yeah, my understanding is that they think, I don't know if they specifically looked at macrophages. I think they think based on the uterine studies. So we have a lot of data about how UPA affects the uterus based on endometrial biopsies that we do in these contraceptive studies. They often see more of the acquired immune system, lymphocytes, and the T cells and B cells, more so than macrophages. So I don't know if that's a bias or if that's also recapitulated in the breast.
Just remember, the immune system is super complicated. Any
Yes.
one of these cell types can be good or bad or both.
Uh-huh.
So it's very tricky.
Mhm.
And then another question came in around at the later end of a woman's life, where she may be taking estrogen and progesterone to counter menopausal symptoms and protect bone density. What are your thoughts on the types of progesterone and estrogen that may increase breast cancer risk? And I know it's sort of a whole nother topic, and
Yeah.
we have talked about it on other forums, but maybe just to answer quickly for this viewer.
Yeah. So, I mean, I think, like Dr. Osterman said, I think there's really good data that Duave, which is a conjugated equine estrogen, which has sort of interesting estrogenic effects. It's not entirely activating. There could be some competitive inhibition or some protective effects. And then partnered with a SERM, the beta-doxephene is considered, likely the
Extremely
most breast
safe.
neutral. The problem with that is that it's oral. And not everybody can tolerate oral estrogens, particularly people that have additional risk factors for blood clots. So for those people, the estrogen that we consider the safest for blood clot is transdermal. And the question becomes which progestin is the safest. And there's, we don't have data about SLIND or drospirenone in the setting of postmenopause. We're hoping to get more data from perimenopause. And there are other studies that look at more bioidentical progestins, so particularly micronized progesterone. We think right now is less breast activating than the synthetics like levonorgestrel from the IUD or norethindrone.
But we don't know that, and everyone
We
just
don't know that.
assumes. I mean, and what's annoying to me is
Yeah.
that everyone's saying that there's no risk from progestins, which is like ridiculous.
Oh, there's
And the
definitely risk
thing,
from progestins. Yeah.
well, but
Yeah.
and they'll say, oh, micronized progesterone is fine when the progesterone that's made by the ovaries has a much shorter half-life than even
Yes.
micronized progesterone.
Yeah.
And Joanne Katsopoulos data actually really shows, I think, pretty clearly. I mean, estrogen itself can be risk reducing.
Hmm.
And when you add progesterone, you get rid of that risk reduction. So
Hmm.
even with micronized progesterone, so I think it's not that you can't ever take it, but I think we should try and go beyond. As you said, so a lot of the mood stuff comes from progesterone. So like, let's go beyond it and find things that are safe and
Hmm.
reduce your risk.
Yeah.
Um, anyway.
No, absolutely. I mean, I think for us right now, OBGYNs right now are having this like identity crisis because everybody and their whole family is coming in for perimenopausal symptoms, and there's
This
such a
is
paucity of
just
data.
how it was, you know,
Yeah.
in the 90s, in
Yeah.
the early 90s, the late 80s and
Hmm.
90s, where
Hmm.
everyone, like, your whole
Wants estrogen.
womanhood is
Yeah.
on the line,
Yes.
you're going to get wrinkles, you're going to
Yeah.
get dementia, and you're going to
Yeah.
be a bitch, and
Uh-huh.
blah, blah, blah. And
Yeah.
everyone must have estrogen, progesterone.
Yep.
That is just not true.
It's absolutely not true, but it's really hard because, I think, one of the things that I hope to inspire is that we need different hormones across the life course. And the
Yep.
hormonal needs of an 18-year-old are different than the hormonal needs of a 45-year-old, and they're different than the hormonal needs of a 75-year-old. And that's okay, right? We shouldn't have a one
And
size
from a
fit all.
55-year-old,
Right.
right? So,
And one
yeah.
of the problems of contraception is that, we have a lot of hormonal technologies that provide contraception and they can also help other things, but they're not really optimized for those other things.
No.
Right. And so it's not that the contraception is bad, which is something that you'll all start getting on your social media if you haven't already, but it's just that they should provide a launching point for improving, right? So we talk in
Correct.
OBGYN, like
And
I
there's
would,
been no
yes,
investment. And like,
exactly.
that's
Hmm.
actually one of the reasons we started the whole Rise Up conference.
Hmm.
Like, what
Hmm.
if we had a contraceptive that actually also reduced your breast
Yes.
cancer risk?
Yeah.
How
Or
amazing would
like,
that be? And
or
by
like,
the way, pretty important since most women are having babies later.
yeah, I mean, I would like an IUD specific to menopause. That's on my Christmas list. Not. Hmm. Yeah.
Oh,
Excellent.
that's
Well,
interesting.
we are out
Sorry.
of time. No, you are great. Thank you so much for being
Hmm.
part of our forum. That was so interesting and so much information. Again, it was recorded, so if anyone wants to go back and listen to any of the parts again, we'll send out an email in the next couple of days with a link to the post that you can re-listen to or share it with friends and family. So again, thank you so much, Dr. Liberty, for being part of our forum, for sharing your knowledge and having a great discussion. And just quickly, next month, because of the Memorial Day holiday, our forum will be 1 week earlier on May 18th. So we will be adjusting the schedule. Since you've all registered, your registration gets you into all future forums. So you should be getting a reminder the week ahead. And I think the topic is still to be determined, but we will make sure to update you as soon as we have it. So thank you so much, everyone, for joining us. Thank you, Dr. Liberty, and I hope everyone has a wonderful evening. Thank you.